So now I can talk about this eye stent. Okay. So as we know, like eye stent is getting very popular, especially amongst cataract surgeons also, because it is not that difficult to do. It is the smallest device, and it is made up of titanium, heparin coated. And again, I think it bypasses the trabecular meshwork, the conventional flow. So we started with this first generation, but now the next generation, and now the iStent W, which is used in India. In finite is still not there. So here this iStent W, which is inserted with the help of an injector, and the eye receives two stents. So this is the design of iStent W. So it is different from iStent Inject, which we had used before this. So it has wide flange, as you can see, 360 micron. And so this has three parts. So the head goes into the trabecular, head and thorax goes into the trabecular meshwork. And this is the part which we see in the anterior chamber. Okay, so this is the magnified version. So again, it has a wide flange, so it optimizes the visualization and placement and enhances the predictability of the procedure. So this comes with this preloaded injector. So I think it is initially very important to understand how you are going to hold this injector and how you're going to retract the sleeve, and this is the delivery button. So how you're going to press it and keep it pressed. So I'm going to talk in detail. And this is the trocar and the insertion sleeve. And here there are two stents. You can see here. And this is the tri-beveled beveled trocar tip with multiple viewing window. So the advantage is that while you are, injecting or you are delivering the stents into the trabecular meshwork, you can visualize the stents coming out of the this trocar. So this is one video. So I think you need to practice, because there are people who are going to start. So first, when you begin your procedure, when you enter into the anterior chamber, you have to, first thing which you do is you have to retract the sleeve, as you can see here, and this is the way it has to be held. And this is the it takes several attempts to learn this. So again, I will show that how you are going to retract it when you go inside the anterior chamber, and then keep your finger on this button, because when you so retract this, like retract the sleeve like this, and then just when you inject the eye stent, you have to click this button. So just want to show you how you're going to do the procedure.
Here we're going to show you a proper implantation inside of a stole line. We want to make sure that the insertion.
So this is the practice eye, which I think you are going to practice in the wet lab. I'm just showing you.
Proper
so this technique. Is the, as you can see, this is the injector and the trocar. When you
just a slight dimple, yes. Light.
When you retract the sleeve, you will see this trocar, which is projecting out. I'll show it again.
I want to show you the proper dimple technique. Retract the insertion sleeve.
So retract the insertion sleeve.
Proper dimple technique.
And you see this trocar.
Pierce.
So you have to just pierce it into the trabecular meshwork and lightly press it, so that you can see that.
Light dimple.
So
light dimple.
You can see that it is slightly, dimpling the trabecular meshwork. So the whole thing is, just slightly dimpling the trabecular meshwork, trocar, as well as the insertion sleeve.
Back away from that side as slowly as you possibly can.
So what you have to avoid is,
what we don't want to do is dimple it
You
too
can
much,
see
which is an over.
this is too much of dimpling. So you need to avoid that.
Technique, which is not actually.
Okay. And the other thing which you have to avoid is not touching the insertion sleeve. And this is called the trocar bias, wherein you are not entering straight, but you are just, the trocar is going the right or the left side. So this is not the right thing. So I think this is very important to understand and practice.
So that we can see the trocar. Rotating my hand
again, then because you have to put it on two sides,
the tissue,
2 clock hours away.
Dimple the tissue.
So here you are dimpling the tissue.
Light dimple.
The trabecular meshwork.
Stent.
And touching the even the insertion sleeve. And just click the black button to implant the istent.
Button. That's the mechanism.
And then you just 2 clock hours.
Second implantation location.
So here
rotate our hands.
It should be at least 2 clock hours away.
Advance.
Again, you have to dimple with the trocar, the trabecular meshwork.
Light pressure. Activate the device.
And
back away from the site.
Implant it.
As we can. Have.
So if you feel that it is not
in this case, this one is
into the trabecular meshwork completely,
decided
with the side of this insertion
step into place,
sleeve tip, you can just push it into the trabecular meshwork.
That stent's now properly placed.
So these are some of the tricks which you have to apply while doing the eye stent. So this I am going to show the under implant. This is again very common when you are not
under implant
indenting, dimpling it properly, and
intentionally
see you are just touching the trocar but not the insertion tube, and you have pressed the black button. So your eye stent is not implanted into the trabecular meshwork, it has come out. So you can just leave this because you have another implant.
We have to make a choice at this
in
point.
The injector. So you just go to the other side.
Plant, or do we move 2 clock
so
hours
you
away?
Go to the other side.
Second stent.
Because the other stent is there.
Great visualization.
You implant the other stent properly by dimpling
stent, 2 clock
the TM. And then come back on the other side. So that one is nicely placed. So then you come on this side.
Second stent.
And rethread it.
2 clock hours away.
So there are 2 ways. Either you just rethread it with the inserter.
Ensuring that the rear lumen.
So you just rethread it in the trocar.
Then we move and 1 clock hour away from the original location.
1 clock, half a clock hour away.
In this case, we have 1 stent in the device, and the rule is
pushing the black button. So this is one way. Another way is that
if you're unsuccessful at rethreading inside the eye, an alternative is to
take it out with the help of
forceps.
This micro forceps, which all of us have. This micro forceps, you can just hold it. It doesn't go here and there. It just remains there because
on the scleral portion of the
in AC there's cohesive viscoelastic
to retain the stent. And easily rethread.
So rethread it outside. I think that is better and more easier.
Rethread.
So you rethread it and then just go back into the anterior chamber.
We advance the insertion sleeve.
And you retract the sleeve so that it goes back, and then again you go into the anterior chamber.
Liz.
And
dimple the tissue.
Okay, so just to recapitulate, that you squeeze the stent activation button with index finger, and you will hear a click when you press this activation button. You will hear a click that indicates that the first stent has been delivered. And don't release this button. There is a tendency that when you have implanted the first stent, you just release this black button. So don't do that, otherwise the implant will come back. You have to keep it pressed and then come out a little and then go on and inject the another stent. So you will hear another click. So the advantage of this istent W is that you have 4 clicks. So even if you have, lost both the eye stents, you're not able to implant, you have a chance to implant them, rethread them again and implant them again. So it has 4 clicks. So don't waste any click. You just try to implant the way, the ideal way, by dimpling the trabecular meshwork. In case if it is under implanted, then you can just take it out with the micro forceps, rethread it, and then again insert it. So this is again, en face view is very important, and because you have to look at the TM straight. You should not look down at the TM. Otherwise, you are not going to implant it in a proper way. And you can see this tri-beveled injector. So you can see this eye stent coming out. So this is way too much of indentation. You don't need to do that much. And this is 2 clock hours. Insert the other one. You can see the blood coming out. So this is the patient. So here I am doing it after the cataract surgery. High viscosity viscoelastic. And you insert it. You inject it. And then you implant the other one. So the distance is little less. Ideally, it should be 2 clock hours. So here, this is a patient with ocular hypertension through medications. And as soon as you implant the eye stent, you see this blood, the egress of blood, which is a good sign. So you can come out and put some viscoelastic, because if your view is obscured by the blood, and then go back. So when you're coming out of the eye, then you have to again, pull the sleeve in the opposite direction so that the trocar is not out. I think these are the things which you have to learn while doing the eye stents. So you can see there's a very nice blanching here. So this is the retrieval. So I was doing this implant, and the first one has gone well, but this one has not gone into the trabecular meshwork. So I removed it with micro forceps, and then I rethreaded it. As you can see, just insert into the trocar. And then retract the sleeve, and then go back again and implant it. So I think this is the procedure. I will not go into the details of the literature review and all, but it does reduce the intraocular pressure. So this is the post-operative picture, and it does reduce the intraocular pressure, and it is minimally traumatic. Actually, you don't get hypema and all the way you get in the excisional procedures. So here in implants, you hardly get any hypema post-operatively, and it does reduce the pressure by 7 to 8 millimeter, and the reduction of medication by 71% in various studies. So I think you can use, in my practice, I use eye stent when the patient has mild to moderate glaucoma, because it doesn't work in very advanced glaucoma. KDB does work in advanced glaucoma, but iStent doesn't work so well in advanced glaucoma. So this was the, in short about the procedure, because it's very important to learn the procedure accurately, how you do the iStent. It is very expensive, so initially you're very hesitant, and you're scared that if you're not able to implant it at the right place, then it will get lost. But you have to maintain cool, and you should know how to rethread it and put it back. But those company people are really good, and they help you and assist you while you're implanting. So for eye stent, I would say that you should have a good microscope and very good visibility of the TM. And pass view is very important for eye stent, so as to place them at a proper position. So
Thank you, ma'am. Thanks a lot. And we have some questions. I'll just request Dr. Akshadeep Jain to ask his questions. He has two doubts, ma'am. So we
yeah, sure.
start with it. Dr. Akshadeep, you can unmute and ask your questions. Can
Good
you hear me?
evening, ma'am.
Good evening.
Ma'am, actually, I wanted to ask, like, an immediate post-op period, should we stop all the AGMs and then again recheck the IOP after a week, and then
Yeah.
again we should?
So we are rechecking the IOP the next day only.
Okay,
So
right, ma'am.
we check the IOP of every patient the very next day. You can do that.
Right,
I
ma'am.
think under sterile conditions, you can, I think, do the pressure, and that should be done, because you would know, will not know how much is the pressure next day. That is good for documentation also, and if you want to start any treatment. But with KDP and all, I've seen that the pressures are generally low, less than 12 millimeter mercury in most of the 90% of my patients. But you have to check.
And ma'am, another question is like, if we are in a primary angle closure cases or primary PACGs, like if we are doing if there is a thick arcus and we are doing a PI in a superior nasal quadrant little anteriorly to the arcus. So is there any difficulties while doing KDB or any mixed procedure?
No, you are not anyway doing anything to the iris,
Right, ma'am.
excising the
Okay.
trabecular meshwork. So there is
Exactly.
no difficulty.
Okay. Okay, ma'am. And ma'am, what is your like experience in pseudophakic open angle glaucomas advanced cases? Like most of the patients here, we are having a 0.85, 0.9 cups. So with inferior rim notches. So
So various studies have suggested that if the patient is pseudophakic and moderate glaucoma, I would say like POAG pseudophakic with very advanced glaucoma, I think it may not be that effective, because patient has been having glaucoma for patient has long-standing glaucoma, and optic nerve is very advanced damage is there in the optic nerve and fields. So I think it is better to do some other procedure, the trab and all. But if you're doing it along with cataract surgery,
yes, ma'am.
then I think it's a good idea, because then you have another chance of doing trabeculectomy as we discussed. But standalone pseudophakia, very advanced glaucoma, I would not like to do KDB and all. Some people are doing GAT, but we are still awaiting the results, how it works.
Right, ma'am.
If because you are answerable to the patient. If you
Yes,
can
ma'am.
convince the patient that the patient may need another surgery, then you can do it. But I think you have to keep your fingers crossed.
Okay.
Ma'am, when the ocular surface is really bad because of the AGM. Hello?
Yeah.
Yes, ma'am.
Ma'am.
So, yes. So, when the ocular surface is really bad because of the long-term use of AGM. So, earlier we used to give oral Diamox, make the surface better, mild steroids. So, now do you prefer to do MIGS to
Yes.
for
I think if
certain
the surface is really bad, then trabeculectomy is going to fail. So I also give steroids, at least prime the conjunctiva with steroids at least a week before. Predfort, the high potency steroids, and you stop the anti-glaucoma medications. So
So now
it's a very
do you
good.
shift to MIGS for like in the interim period, however it's working, and then maybe do a trab later?
Yeah, I think that's a good idea. But again, I think as we discussed, if the patient is undergoing cataract surgery, then you can do that.
But
But if
not
the
as a
patient is having
standalone.
intractable pseudophakic glaucoma, then just MIGS will not work that well.
Right
So
now.
it is better to control the inflammation of the conjunctiva, give steroids and lots of lubrication, and do the trab. If trab is not possible, you can do tube in such patients, the non-valve tubes. Mm.
Ma'am, for iStent also, do you use it before cataract surgery? Do you do it before cataract
I
surgery or
do it
after?
either way, but like after cataract surgery also I've done a lot. Before or after you can do whatever you are more comfortable with.
Ma'am.
In
And
very,
in your eyes,
huh?
no, ma'am, please continue.
No, in very open angles, I think you can do it, but then be careful that uh, you have implanted them properly. And, because if you are doing PECO and if you're close to eye stent and all, then you can, suck them also. If they are
Okay,
not
ma'am.
properly, if they are under implanted. So you need to ensure that they're properly implanted.
Thank you, ma'am. And ma'am, one more question. I've noticed in all your videos you are using that either Katina lens or the Swan Jacob lens. So for the
Yes.
iStent also, you're not using that eye prism.
I have eye prism, but Katina, we have multiple Katina lenses, whatever is
Oh,
available. So
okay,
I
okay.
don't find any difficulty in Katina lenses. They're good.
Mhm. Thank
You
you,
can
ma'am.
do either of them. You can use eye prism also.
Mm.
Mm. So it is all like, the microscope and the lens, whatever lens you're comfortable with. And if you use that lens all the time, then you become more comfortable. So earlier I used to use a Swan Jacob lens, but it is smaller. Katina is quite big.
Yes, ma'am.
So the magnification is more and you don't have to move the lens. For the Swan Jacob, you have to keep rotating it because it is a small diameter. So you have to get used to, one type of lens and then you become comfortable with that. Swan Jacob, because it's a non-disposable lens, it lasts very long. And although it is expensive to buy initially, but then it lasts for several years. Even disposable lenses also you can, keep using them, ETO them and keep using them. So whatever I think you can make yourself comfortable.
Thank you.
Ma'am, we are giving our Katina lenses to all our trainees so that they can go back and start practicing mix and at least start visualizing the angles. So
Yeah.
we are giving everyone, we are giving one lens so that they can take it back and start
Okay.
practicing.
Very nice. Mhm.
So we'll
You
go.
people are doing eye stands also?
Dr. Gaurav sir
Ajay,
is
Dr.
doing
Gaurav
right
is
now.
doing.
Yes,
Mhm.
ma'am. Sir, do you want to share your experiences with the eye stent, sir?
Yeah. So, I think there's a learning curve, and we've just done a few patients. And, I've had to rethread a couple of times also, once inside the eye, once outside.
Yeah.
And, but after that, then of course, it goes well. And I think what you said is the most important thing. You should have a good view of the TM. And for the eye stand, it's more important that you have a nice, clear view and a proper, good microscope. I think those things make a lot of difference. But otherwise, the procedure itself is straightforward.
Yeah.
And
Mhm.
So I think very nice tips. I really learned. The only thing I thought was that I know that IKMR does the eye stent also before doing the cataract. Do you also do
Yeah.
the eye stent before the
I
cataract
have done
surgery?
that is what I have done
Mm,
in
mm,
few. Actually, I started with trabectome, and that is
mm,
why I learned to do it because trabectome, it doesn't work. It's a plasma cautery.
mm,
So it didn't work when there's little amount of even viscoelastic in the angle. So
mm,
it had to be done before cataract
mm,
surgery. So I
mm,
learned that way only. So most of my
mm,
makes, even hydrous now I'm doing before cataract surgery.
mm,
So
mm,
if you can visualize the angle well, and if you have put Helon GV in the anterior chamber, the AC deepens. And even if the pupil is dilated, because we keep the pupil dilated for cataract surgery, so it doesn't make any difference. Dilated pupil, and you just press the iris with high viscosity Helon. So
In fact, that was my next question: that how important is it to put pilocarpine, when you're planning to do an eye stent or a KDB? Because in an open angle, of course, it will be straightforward.
it is not important.
It's not very important.
It's not very important. Only thing is that if your pupil is small, if the eye stent actually, for the eye stent, because if it gets dislodged and if you're under implanted, and if it gets, it moves inside the anterior chamber. If the pupil is dilated, it can go behind the iris. I think that is the only thing why you should constrict your pupil if you're doing it after your cataract surgery, in case if it could not be implanted properly. I think that is the reason. Otherwise, there is no, need for pupil to be constricted.
Thank you. Thank you, ma'am.
But eye stent initially when you're doing first, I think it is scary because, dealing with a very high cost device and you want to do it perfectly. But after doing 8 to 10, then, it comes in muscle memory. You just go in and click the button and it
I
goes.
know. One of our patients, we had a problem because there was active bleed when we put the eye stent, even the first one, and there was a very active bleed which wouldn't stop. And then and even at the second implantation, when it didn't implant properly, and then we had a major problem because that whole thing, it got coated. In spite of putting a lot of viscoelastic, the blood wouldn't move away. So there was one very challenging eye stent as well that we had. So I don't know. I mean, that patient probably, even though he was off anticoagulants and everything for almost a week, his even from his main corneal incision, everything. Some patients tend to have more kind of ooze, and they are the ones where you can have a problem
Yes,
with
yes.
this.
So
So
the other thing is that now what I do is that, because initially when you just sit in one position and try to implant, you have to move your hand like this, and then like this.
right,
What I do is that I sit slightly
to
off
one side or the
on
other
the
side.
one
I
side
understand.
and then do it and then come out. So
Mm-hmm.
you just, one at a
That
time,
makes sense.
come out and then shift your position on the other side and then
Mm.
do it on the other side, 15 degrees offset.
Mm.
So I think that helps you to space out the eye stand and you can cover a
Mm.
wide area.
Right.
So initially, so you are, just insert one and then come out.
Mm. So I was told that IKMS, that lens, which is where you don't need to tilt the head because it's the eye
Yes,
prism.
yes, yes.
But apparently the view is not as good as
As good
I've
as,
never used it. So I mean that would be counterintuitive because if for a very experienced surgeon, I'm sure it'll be straightforward because they know what they're looking for. But otherwise, you really want a good view of the
good view is, I think,
TMs. So,
essential. Even for an experienced surgeon, I think you have to see to implant an eye stent. Otherwise, I think if you're not able to see, then, and I think it should not be done in closed angles. KDB can be
right.
done in all types of glaucomas, but this has to be a very straightforward open angle, mild to moderate glaucomas.
Right, right.
That is what I have realized over a period of time, that the indications of eye stent are not as broad as the
I
other,
agree.
yeah, GAT and KDB.
Absolutely. Thank you.
The patient expects a good result because the patient has spent so much, I think, and you have to give, very good results.
They really expect a lot, and even post op, then they keep wondering that how well, even though IPs are very well controlled, if they are not very bad glaucomas, if
Yes,
they are like mild to moderate glaucomas, they do iStent works quite well, but then expectations are always very high. That's the biggest
expectations,
problem.
yeah. So counseling, like whosoever is starting mixed procedures, I think you have to spend 10-15 minutes with the patient for that for any glaucoma procedure. I think it's not like cataract that patients are mentally prepared. So you have to counsel them a lot, and tell them about the success of the procedure and the lifelong follow-up and need for another procedure. So it is not just one surgery that will last for lifelong. So I think for glaucoma surgeons, you have to really spend time, whether you're doing MIGS or you're doing trab or tube or whatever.
Thank you.
over expectations sometimes have to be dealt with patients.
So I think you have to um, overperform and under promise. This is true for glaucoma surgeries.
Yeah, definitely. Yeah. So, any other doubts from Dr. Smriti Jain, ma'am, Dr. Sakshi, Dr. Ekta, Dr. Pooja? Any other doubts, or should we?
No doubt, sir. It was really well covered, and the discussion was also good. No doubts.
Yeah, the
Thank
videos
you,
were
Dr.
very
Ekta, ma'am.
clear, Dr. Sunita. Very
Okay.
good demonstration, everything. Very excited for the workshop and to
Okay.
see you. Yeah.
Thank you. I am also looking forward to the 25th, 24th, 25th event now, the
Yeah.
conference.
Thank you so much, ma'am. We are looking forward to learn a lot from you. And the fine tips that you gave us, they are really helpful. I hope we can just incorporate in our practice and maybe we can achieve a bit better results.
Okay. Thank you.
Thank you so much, ma'am.
Thank you. Okay.
Ma'am, we can discuss about the details about it, ma'am.
Yeah, you can share your this thing, screen and
So, is my screen visible to all?
Then I check out or I have to?
Yes, sir.
yes, ma'am, you can. Thank you so much. Thanks a lot. We'll be
Okay.
sharing just the wet lab program now with the
Okay. Okay.
Thank you
ma'am.
so much, ma'am. Thank
Okay.
you, ma'am.
Thank you. Thank you.
Thank you so much, ma'am.
Thank you, ma'am.
Right, ma'am.
So I'll just share the details how we are gonna do the wet lab for 24th and 25th. So be very clear that it's on 2 days and we'll having all the 4 sessions simultaneous. Like we'll be having 4 microscopes in the wet lab. So this is the whole, just consider this to be a overlay of our wet labs hall. So there'll be 4 microscopes placed and there'll be you all will be divided into 4 groups. So each group will be having 5 participants. We had around 34 entries for the wet lab. So we had shortlisted and we have requested and we have finalized only 20 people so that we can have one-to-one interaction and maximum people and should gain and you should have like it shouldn't be very much overcrowded. So we have shortlisted and we have requested many people and we had like came down from 34 to only 20 people now. So each group will be having 5 people, and you all will be divided randomly in the group A, group B, or group C, or group D, and we'll be having each 4 station with 4 microscopes. So this again I'm saying, so the hall will be divided in such a way that 1, 2, 3, and 4 microscopes are kept like that, and each group has 5 candidates, and you'll be getting one microscope for 15 minutes for one particular thing. So coming on the sessions, we'll be starting sharply at 2 p.m. On the 24th. That would be the first day. That will be first will be your intraoperative gonioscopy. Am I audible? Is it my slide visible?
Yes, sir.
Yeah. So intraoperative gonioscopy will start at 2 p.m. and it will go up till 3:30 p.m. And these will be our instructors. We have requested the instructors will start teaching you. And again, I'll go back to the previous slide. So all 4 sessions all 4 microscope from 2 o'clock to 3:30 will be intraoperative gonioscopy in all the 4 counters, all the 4 microscope and all the 4 sub areas of the wet lab. At 3:30 p.m. we'll switch over and the group A while people will go to group B while microscope and group B microscope people will go to group C while microscope and group C people will go to the group D microscope. So that we can have a like equal opportunity to all type of microscope because we have three different type of microscopes. So we want everyone to have an experience of every kind of microscopes. So we're gonna switch that also. So for this also, then we'll 3:32 p.m. to 5 p.m. We have istent session in which will be our instructors. And again, I'm saying it will be 15 minutes for one person to perform, and the rest 45 minutes you have to observe what the other person is doing. We'll try to keep it as we'll stick to the schedule as far as possible because we are starting with the UOC session, Young Ophthalmic Society session, from 4 to 5 p.m. So by 5 p.m., our main session, the medical session, and followed by a trabeculectomy session will start. So before that, we'll try to wind up. So we have to keep the schedule of, and we have to keep that time limit of 15 minutes per person. Right. So this is for 24th, that is Saturday. And Sunday morning, 25th, we'll be starting. I know it's a winter. I'm really sorry to wake you all at morning 8 a.m. And I know it's very difficult for some people, but we have to do it because we have a lined up session for 25th also. I'll be sharing soon. So I know I'm really sorry to wake you up early morning, but we'll be starting at 8 a.m. in the morning. And the first session will be on KDB. Again, it will be for 1.5 hours. 50. Again, I'll go back. So all group A, B, C, D, all four microscope will be dedicated only for doing KDB and for that session. And in that 15 minutes per person, we'll be finishing up that session by 9:30 a.m. And these are the instructors for that session. And followed by it from 9:30 to 10:30 a.m. I am expecting, because it's a bang is just, we have to tell you how, because by the time you have mastered KDB, so you have to just learn how to bend the needle, what's the best way to bend the needle, how to go about it. So this bang will be a comparatively a little shorter session, and we'll try winding up by 10:30 a.m. because by 10:30 a.m. we are starting the main session in the hall A, which is this all will be happening in hall B, the wet lab hall. And then by the time by 10:30 a.m. the hall A, we are starting the mix session, MIGS session. So that's really important for you, all of you, to attend and understand and see the deferred live videos, and all these faculties will be sharing their own videos side by side for it. Along with this, we also have, just beside the wet lab hall will be the 3D video booth or 3D video hall, which we'll be having. So all these istent, KDB, intraoperative gonioscopy, and even GAT, and some newer mix, and even trabeculectomy, all things you can visit anytime. Whenever you have time, you can go in between and start seeing the 3D videos of all these surgical or glaucoma surgeries, including TRAB, including GDDs. So you can not only just MIGs, other glaucoma surgeries will be also be projected in the 3D hall. So you can just have a look and have an immersive view of the MIGs. So I'll just stop sharing, and I request you to share your doubts, if any. Dr. Madip, ma'am, do you want to elaborate some points, ma'am?
No, I think the program is nicely covered. You've already elaborated on everything. And I'm sure there are no doubts. If there is anything, please feel free to ask. It's just a few of us now, and there is no instructor present amongst us in the group right now. So anything from anyone? Do you have any specific this thing about time? If anybody is reaching late, so that we can assign a bit different this thing, or we can try and manage something. I would request you all to be here by around 11 or 12 maximum, because that day there's going to be a peak traffic also. So just try and be at the location by latest by 12. Relax for some time so that we can join the session on time.
Okay. Just a question. Since the videos have been recorded, can you share them before we have missed a part of it?
Definitely, sir.
We'll
Dr.
definitely
J,
share.
Dr. J, you have recorded all the sessions, and ma'am, we were trying to give it in pen drive kind of form, but I think so we'll not be able to do that. So we'll be sharing through WeChat only, and there's a downloadable links for that, sir. Definitely we'll do that, sir. And
Dr. Amardeep, you had said
Ma'am,
the sessions will be starting from 2 o'clock, right? So,
ma'am, the wet lab we are starting at 2 o'clock, ma'am.
yeah. So, what time is the reporting time? Should we just come around 2, like 1:30?
Ma'am, yes, ma'am, because you're local, so you can come here by
Yeah.
around 1:30. So just have a cup of tea or something, and
Yeah.
by the time the session starts,
Yeah,
you're
all right.
fresh.
You said no, 11, 12. I was like, itni jaldi aake
No,
kya
no,
karna
ma'am,
hai?
for the
So, just wanted
outstation
to
people,
know.
because
Yeah.
quite a lot of them are coming from outstation. So I
All
would want
right.
them to just take care of the fatigue which they've undergone.
Okay, okay. All right. Thank you.
And Dr. Akshadeep, the scientific schedule will be sharing soon. But just I'll repeat for everyone. So from 4 to 5 p.m., we are having the UC session, in which we are starting with the basics of glaucoma. So I know you all are practicing good, so I don't think so we should, that's for young ophthalmologist, and so that our session start from 5 to 6 p.m. we have the medical session. From 6 to 7:30 we are having the deferred live and video assisted skill transfer courses for trabeculectomy. From 7:30 onwards till 8 o'clock, we have the international guest speaker, Dr. Devendra Grover, sir. He'll be speaking on interventional glaucoma and the newer glaucoma and IVent and many more things. From 8 o'clock onwards, 8:30 onwards, we'll have an inauguration session, followed by a 90s Bollywood theme gala night dinner. And from next day morning, from 8:30 a.m. till 10:30 a.m., we have case presentations from PGs and fellows only. Like PGs, and we have around 10 submissions from PGs and fellows, and they are case presentations which will be they presenting. From 10:30 onwards, we are starting again the main session on MIGS, and the sessions has been created like that so that you don't miss on any of the important sessions, and because many people were asking this thing on doubt, like whether we'll be missing all those sessions. So nobody's going to miss any session. We have curated like that only. So all that surgical part of the session will not be missed. We have and that's the reason I want everyone to be, so that we also will also try our best. Dr. Madip man, our volunteers will be there, and many other people will be there to help you finish off in that 10-15 minutes. And we have like company people also will be there to guide you, and we all will try to stick to that 15 minutes per person slot, and that's what we are looking forward to it.
Yeah, and that's why we have kept the bank as last, because bank it's not going to take much time. You by that time you must have already learned KDB, and you just have to learn how to bend the needle and how to have the proper angle and everything. So I don't think that's going to take much time with the last session. And by the time the this interesting sessions are starting, you'll already be free.
Dr. Astha ma'am, are your doubts clear, ma'am? Dr. Astha Patolia ma'am. Hello. I think. Oh, thank you.
Yeah.
Yeah. So I just want everyone's. I hope there is no confusion.
So just one last thing. On
Yeah.
25th, at what time does it end?
We'll try, ma'am, because the only reason we are so rushing up all these things, because our invited guest speakers have flights around 3 o'clock, so they'll be leaving by 1:30. So expect that we are planning to finish it off by maximum 1:30, and then followed by the valedictory session, which we all will be given us certificates in like a convocation kind of thing. We are planning a convocation ceremony for all the attendees. So 1:30 we'll start that inauguration, that valedictory session and the distribution of certificates, and maximum by 2 we can wind up with the lunch.
I think it will be
Oh,
a good idea if all of you can share your travel plans with us.
yeah, that would be better, I think, if we
Yeah, because they
share
would
the.
definitely want you to take the certificate along with you, and the gonio lens also.
Okay,
So
sure, we'll share that.
So on the group which we are there, just the MIGS Wet Lab trainees are there. You can please share your travel plans.
People
Okay,
coming from
sure.
outside doing it.
Yeah, only for the outside people. Dr.
Okay.
Samriti, we can call anytime. So again, if there is anything you can ask on the group also.
And we have our numbers are there. You can call us anytime and you can ask. So see, I think so. I don't want anybody getting confused on the last day, like what way we have to go. So the groups are randomly generated only. We'll try to finalize that in 1 or 2 days, and which people will be going to what station at what time. Like it's everything will be happening simultaneously on all. So we want the things to go smoothly and like step by step by step. That's why we are doing all 4 things together. And the idea behind conducting a comprehensive MIGS was like to doing what is the most 3-4 common MIGs being done in India, so that you go back just by not doing just a single mixed procedure. You should, like if I would like only KDP, only istent will not be a good idea. So you should learn each and everything. That was our idea behind conducting this comprehensive wet lab.
And most of the wet labs, they don't show the gonioscopy, which is the very basic step of MIGS. So that is why we are keeping the intra-op gonioscopy as the first session, so that you are well versed with the gonioscopy first and then proceed with the istent or KDB. So I think we can wind up the session now. I think if there are
Yes,
no
ma'am.
further questions or queries.
Yes, ma'am. Thank you all.
Thank you.
Thank you
Thank
so
you.
much, Dr. Smriti ma'am. Thanks a lot for attending the session. Thank you all I will not call them trainees. Dr. Prasanna used the word neophyte, so I like that term, neophyte. Right. Looking forward to see you soon. If there are any questions, please feel free to ask on the group also, or maybe you can drop a personal message. It's okay.
Thank you.
Yeah, thank you.
Thank you all.